Now, before I get into the cases, I'm just going to do a very quick summary of what we talked about, okay? The peak VO2 at rest is typically around 250 with a ml per minute, but it can vary plus minus 50 depending upon your resting expenditure or metabolic expenditure, okay? And then what the point of this is just going over some of the normal cardiopulmonary responses to exercise. So VO2 can augment up to 12 to 18 times normal at rest. So it is something that you want to keep in mind to have a ballpark of what someone's peak VO2 should look like. I also told you last week that in general, if your peak VO2 increase is over 20 mLs per kilogram per minute, that's generally okay. It's a good prognosis either way. It could be mild impairment. It could be disease related, that you could have a higher peak VO2 in that and still have disease processes. But in general, it's considered mild impairment. And generally speaking, most of the peak VO2 prognostic studies suggest that the prognosis is very reasonable, okay? The second thing to go over is heart rate. Heart rate can augment 2 to 3 times, 2.5 to 3 times normal. And I told you the way to calculate, it's everyone knows this who works in a stress lab, that it's 220 minus H, and at least 85% of that you want to attain as considered a full heart rate response to exercise. And the heart rate recovery, if you remember, I told you that after someone starts exercising in CPET, we wait for 2 to 3 minutes with the mask on because we're measuring the gas analysis, but also looking at heart rate recovery. And so less than 12 to 15 beats. So it varies from studies to studies and centers to centers, but less than 12 beats per minute is definitely abnormal. Some consider less than 15 beats per minute as abnormal. And like I told you as an example, if someone's peak heart rate is 165 and at 1 minute it's still 154 or 155, that is an abnormal heart rate recovery. It is a poor prognostic sign both in CAD as well as in heart failure. Stroke volume. Stroke volume is something that in a normal responses, you can augment it twice. Maybe if you have a 50 cc stroke volume, you can make it go up to 100, maybe 120, but not more than that. So that is why during a cardiopulmonary exercise test, around anaerobic, at or around anaerobic threshold, the further augmentation of peak VO2 or cardiac output is based on increase in heart rate, not stroke volume, okay? And then cardiac output, as you all know, around rest is generally taken as 5 liters per minute. And you can augment that up to 4 to 5 times with exercise. So it would not be unusual to see if you were doing an invasive study like an exercise right heart catheterization to have a peak cardiac output around 22, 25 liters per minute. It's a normal response and rather expected. Okay. Now, the minute ventilation can go up dramatically. So in general, 5, 6 to 8 is basically liters per minute is what we normally breathe, 5 to 8 liters, but it can go up 20 to 25 times that, okay? Almost up to 180 liters per minute at peak exercise. So these are the normal cardiopulmonary responses to exercise. This is what we went over last time. This is kind of the normal test parameters. Let me point out too, a alveolar arterial gradient or AA gradient and VD upon VT, which was the dead space ventilation that I went over. Just consider them as like being gas exchange variables. They're markers of your gas exchange at the alveolar level. So either if not enough blood is getting through the capillaries, that will be abnormal. If it's destroyed, like the alveolar capillary membrane is destroyed, like in emphysema, you will have gas exchange abnormalities. These two parameters will be abnormal. Or if there's thickening, like interstitial lung disease, where there's scarring, you know, there's the thickening of the alveolar membrane, that will also cause. So gas exchange abnormalities, these two CPET parameters, VD over VT, which is a measure of the dead space ventilation, which is normally around 25 to 35%. As I told you, once with exercise that improves, okay? So it should decrease with exercise. And an alveolar arterial gradient, that is usually 5 to 20 millimeters of mercury. And if it's over 35, it's clearly abnormal at peak exercise. In general, it should remain relatively stable or decrease with exercise, okay? Maximum heart rate, we already went over. Tidal volume, around 60% of your forced vital capacity. Beyond that, when you're exercising, because as you know, with exercising, you breathe faster as well. So you never can like breathe at your forced vital capacity, which is your complete, capacity of breathing. You basically are at 60% of that. Minute ventilation is at peak exercise. In normal people, you never reach your ventilatory threshold. As I told you last time, that most people, even if you're normal, you're limited by cardiac limit. You're limited by your cardiac output, not by your ventilation or ventilatory threshold or ventilatory reserve. O2 pulse, in general, to numbers to keep in mind, is greater than 15 mLs per beat in men and greater than 10 ml per beat in women. Less than that is considered abnormal, but O2 pulse, as you know, the equation is VO2 over heart rate, and both of these are predicted. So every CPET that you'll read will have a predicted O2 pulse, and then you can compare whether the patient reached that O2 pulse or not at peak exercise. And O2 pulse, as you know, is a measure of stroke volume, okay? This SaO2 oxygen saturation is self-explanatory. We talked about VE/VCO2 in detail last time. That is a marker of ventilatory inefficiency. And I told you it's just a measure of ventilation perfusion matching. RER, respiratory exchange ratio, at peak exercise, we want it to be around 1.1 or more, and that suggests an adequate effort. And I also told you some people will not reach that who have like COPD, for example, because they will be limited by their ventilation well before they hit their anaerobic threshold. And this is when this RER really starts going up, is when you reach when you hit the ventilatory threshold, okay? Now, this is just that reminder of the equation of how you calculate the dead space, VD upon VT. Basically, you need an AVG. That's kind of the crux of the matter. Now, these are two things that I want to go over. I'm hoping you guys will track this. It's addition to what we discussed last time. There's a relationship known as the VO2 peak. This is the VO2 to work rate relationship. And this is best done with a cycle ergometer, because you know exactly how many watts the patient's exercising. You have complete control of it. And as long as they're cycling within that RPM that you set for them, like 60 RPM, they should be working this amount of watts. And this relationship is usually linear. It is linear in everyone. And the equation is that per watt of exercise, your VO2 goes up by 10 mLs per minute, okay? So for example, in a condition like heart failure, what will happen is that what is heart failure? Or heart failure is a process in which you cannot deliver the oxygen to the working muscles. So as your work rate is increasing, with a circulatory or cardiac impairment, you cannot get the oxygen delivery to the exercising muscles, and hence this number decreases. Does that make sense? So your VO2 will go down per watt because you're just not getting enough oxygen delivery to the tissues. Now, this can also happen in peripheral arterial disease when you're not getting enough oxygen to the because of the stenosis. But in general, if your VO2 work, you should always look at the VO2 work rate relationship and look at that number, and it will help you in terms of an additional parameter that can tell you about cardiac output limitation. All right. Now, this is one concept that we don't have here, but this is not some research concept. There are a lot of labs out there that have this pretty standard. So because it's a different type of CPET machine, but there are several CPET machines out there that can now give you non-invasive cardiac output assessment. So they can, I'll tell you how it's done very briefly, but non-invasive cardiac output assessment, and that becomes important when you're trying to tease out some conditions, which I'll go over in just a moment. But the concept is that there's an inert gas, okay? This is a non-breathing bag. So this is a bag that has an inert gas like nitrous oxide. It's inert, so it's not metabolically active. So basically you will breathe that and it will measure 5 to 6 breaths and it will measure the washout of this gas. And as long as you don't have a shunt, it will measure your pulmonary blood flow, which is equal to your cardiac output, as long as you don't have a shunt, like an ASD or a ASD or an intrapulmonary shunt. Basically, those are the two main ones. So you will, okay, now this has been tested against cardiac MRI, cardiac output. It has been tested against invasive right heart catheterization and direct FIC measurement. And it is about, the R on it was about anywhere from 0.7 to 0.8. So it was a good agreement, and it has used now routinely in some of the labs to measure non-invasive cardiac output. So what can be one of the utilities of having that in the CPET lab? Well, let's look at this. So there's something called, on this y-axis here is your cardiac output, and your VO2 is on your x-axis here, and there's a delta Q to delta VO2 relationship here, this curve right here. It is also a linear relationship, and it does not change in whether you have cardiopulmonary impairment. So cardiopulmonary diseases do not impair this relationship, okay? Now, let me go back up here. Now, if you guys remember, peak VO2 is equal to heart rate times stroke volume, which is your cardiac output, which was the Q, times the arterial venous oxygen content difference. Now, just assume for a moment that you have something like you don't have a heart problem, you don't have a lung problem, but you have a skeletal muscle problem, a myopathy, for example, a mitochondrial myopathy. Now just think about it, what will happen in a mitochondrial myopathy? The problem is it's not the oxygen delivery. So the delivery is coming from the cardiac output, right? That's how you're delivering the blood. It is not a problem of oxygen delivery, but it's a problem of oxygen utilization. Because of the mitochondrial myopathy, once it hits oxidative phosphorylation, it can't use the oxygen to produce energy. So it will go hit anaerobic metabolism very much sooner. But because of that, because you can't utilize the oxygen, just look up here. So look at this, your CA2, there will be no problem in oxygenating the blood. But on the venous side, your VO2 will be very high because you haven't extracted the oxygen. You haven't utilized it because of the myopathy. You're unable to utilize the oxygen. So this number, say this was 99%, now this is 74%, this number will be like 25%. Under normal circumstances, it's like close to 80%. So if this number is low, your peak VO2, just by the equation, will be low. So your peak VO2 is low, not because your cardiac output is low, but it's low because you're not utilizing the oxygen peripherally. Does that make sense so far?
It makes sense.
Okay, all right. So as a result of this is what's going to happen. So this is normal, and this is, I've given a condition of how the curve will look like with a mitochondrial myopathy. So you will hit anaerobic threshold early. You will start developing lactic acidosis. The natural response of the body will be, in fact, to augment cardiac output. Because there is not a heart problem, your cardiac output, which is on your y-axis, will increase way more for very minimal change in peak VO2. So this curve will be shifted upwards. In other words, your peak VO2 is not going up as much. If you didn't have this non-invasive cardiac output, you would have assumed wrongly that there's a cardiac output impairment. But because you have the non-invasive cardiac output, you'll see that augmenting beautifully, in fact, more than normal, this is the normal increase in cardiac output with exercise. So it will be increased more than normal. This relationship will change, and your peak VO2 won't go up by much. So in normal, this slope is like 5 liters per minute. In a mitochondrial myopathy, if you measure the non-invasive cardiac output and peak VO2 and you look at the slope and the ratio, it can go up to like 15 liters per minute. And that will suggest that there is a peripheral oxygen utilization problem. And then you can focus your further testing on, say, for example, getting a muscle biopsy. All right? So those are the two nuances above and beyond the standard CPET parameters that I told you guys. Okay, so with this knowledge.
Can I ask you a question?
Yes, Arvind.
You know, it's
title this mechanism, I don't know how portable it is, but the concept of peripheral utilization versus output from the heart comes up in cardiogenic shock in certain situations where
Yes.
we see tissue hypoxia.
Yes.
Has anybody, do you know of any studies where they utilized this in shock patients to demonstrate?
Right. So not directly in shock patients, Arvind, but let me tell you. So what happens is, as you obviously more aware than I am, that these advanced heart failure patients, they tend to develop a skeletal myopathy, and they have a skeletal muscle myopathy, just like a true myopathy, a primary myopathy. So they have problem of peripheral oxygen utilization, but the problem there is that the cardiac output is also low. So this slope normalizes falsely. So there may be a combined problem with peripheral oxygen utilization, and because the cardiac output is not augmenting properly, so this curve goes right back towards normal. So it looks normal, and you can't tell the difference in that case. So what you can do, though, in those people, there are studies where they do catheters, and they're measuring real-time lactic acid using gas analyzers. But that's the problem with this, using this technology to look for heart failure associated skeletal myopathy, that it kind of counteracts each other and the curve looks normal. So this is a word of caution that when you're going to look at the various parameters, you may see some that are overlapping. So as you know, CPET is looking for the primary limitation, okay, the primary limitation. So that's why you do CPET. You're trying to tease out, you're not saying that there's no other comorbidity existing. People may have some COPD and they may have heart failure, but what you're trying to tease out is what is the major cause of their functional limitation. So it's called, this is the balance approach. The more pointing towards one, then you want to call it as such and not confuse the person who's ordered the test, because you have to give them some appropriate answers. Now, this is a AHA algorithm. This is a very bird's eye view type of algorithm, but let's just go over it because it'll give you some sense when we start going into our cases. So you're going to look at peak VO2. If it's normal, greater than 85% predicted, then really there's not much significant pathology. Either there's very mild disease, or you're dealing with obesity deconditioning, or you're dealing with anxiety. Some people are just anxious and they have symptoms of dyspnea and exertion. But if it's low, less than 85% predicted, go to the anaerobic threshold. If the anaerobic threshold is less than 40%, which I told you that's what it's considered abnormal, then you look at the breathing reserve. If you have a good breathing reserve, like more than 30%, then low peak VO2, low anaerobic threshold suggests cardiac or circulatory impairment. If your breathing reserve on the other end is low, that means now you have a low breathing reserve and you have a low anaerobic threshold. This can occur. I remember I told you guys about the pulmonary vascular disease and how it can look like a mixed picture of both ventilation and cardiac output limitation. Then it will be a mixed lesion, something like pulmonary vascular disease. Now, if on the other end, your peak VO2 is less than 85% predicted, but your anaerobic threshold is greater than 40%, which is normal, then you look at the breathing reserve. So if the breathing reserve is low, that means you have reached your breathing reserve, which is only possible if you have a ventilatory impairment. If on the other end, you have a low peak VO2, less than 85% predicted, but you have a normal peak, normal anaerobic threshold, and you don't have a low breathing reserve, you have a normal breathing reserve, then you're again dealing with either it's a poor effort, you can look at the RER, or you're again dealing with deconditioning. All right, so, and then one last comment before we get into the cases is this unique situation of chronotropic insufficiency or chronotropic incompetence. So when you have chronotropic incompetence, just think about it. Chronotropic incompetence means that your heart rate doesn't come up appropriately with exercise. You will have a low peak VO2, but that is not because there's a cardiac output impairment. That's because your heart rate is not going up appropriately, which is part of the equation of cardiac output with stroke volume times heart rate. So how can you tease it out? You look at the O2 pulse, because I told you the O2 pulse is a measure of stroke volume. So here, the heart is not unable to augment stroke volume. So in other words, your VO2 over heart rate, which is your O2 pulse, the number will actually be high. And you will not have that early plateau that you see with stroke volume limitation. So the O2 pulse can be very critical in distinguishing chronotropic incompetence from heart failure with the inability to augment stroke volume. Okay?
Imad,
All right.
quick question.
Yes.
Go a couple slides, and maybe you'll point out in the reports or the cases.
Yes.
One more slide back. The distinction between RER versus low, because we use RER to know whether they've reached anaerobic threshold, right?
Right.
So the distinction between the normal or low anaerobic threshold versus RER per se. So how is it being represented?
Right. So basically, if you hit anaerobic threshold early, if you're saying if like a low anaerobic threshold, like early into exercise, you hit anaerobic threshold, the chances are your RER would exceed 1.1 at that time. It will basically at that time, your RER would exceed 1. And whatever exercise you're doing beyond that, you're using a combination of anaerobic metabolism and aerobic metabolism, but you are basically not underperforming. You are truly giving it your best effort, but it's just occurred very early on because of your limitation, cardiac output limitation or oxygen delivery, lack of oxygen delivery. So there are other differentials for that, right? So, but yeah, RER will be early. So you'll hit a 1.1, 1.5 way early into your exercise, and then you'll stop prematurely. That's the problem with these patients, that if they hit anaerobic threshold early, they just stop very early into it, so they don't get much minutes in terms of exercise. Okay, so let's get into the, the first case is sort of setting it in, right? Okay, so basically I want you to learn how to look at the variables and go on, so on and so forth. So 38-year-old man who's performing a cardiopulmonary exercise test as part of his orientation to cardiopulmonary exercise testing. So just like a volunteer, physically active person with no exercise limitation. All right, so first thing we'll look at height, weight, 70 kilograms. We'll do the Pfts. That's the first thing that's done. The spirometry, FEV1 is 4.6, which is 105% predicted. And then it'll give you this, your spirometry. Now I told you can use FEV1, 4.65, and multiply by 40, which will get close to 180 as your maximum voluntary ventilation, or you actually measure it by having them taking deep breaths in and out for 15 seconds and then multiply by 4. So in this case, the expected maximum voluntary ventilation for this patient is 181 liters per minute. Got it so far? Next, we conducted the exercise test. This is one table you'll get. So this patient went to maximum watts. He did 402 watts of exercise, which is 142% of what the prediction was that he would do. Your peak VO2, this is in mLs per minute, and this is indexed to kilograms per minute. So his peak VO2 was 62.8. His predicted for his age was 44.9. So this is 140% predicted. So he's overperforming for his age and height and weight. And then you look at the heart rate. So resting heart rate 74, at maximum it was 184, and his predicted max was 185. So he reached his full heart rate threshold. O2 pulse, mLs per beat. Again, so I told you in general, over 15 is normal. His predicted maximum was 17, but look at his O2 pulse was 23. He's almost like an elite athlete. So this is what this is showing. Blood pressure response, it should increase with exercise, and your diastolic should typically go lower or stay stable, and you can see it went down here. So ventilation, and normal people should not reach maximum ventilatory threshold. Maximum ventilatory reserve. But this guy did, and that is only possible. The only exception to not reaching that is if you are an elite athlete. So his was 180, as you saw from the NBV, predicted 181 liters at peak exercise. He actually exceeded it to 190. And so this is the only exception where that doesn't happen. Respiratory rate went up to 16 to 70. tidal volume increased appropriately with exercise. O2 saturation remained the same. And PET CO2, which I told you once you're hyperventilating towards the end of exercise, you should ward off CO2, so it should go down. So PET CO2 went down appropriately. Reason for stopping test was leg fatigue, which is predominantly the case with cardiac output limitation. And like I said, all people are cardiac output limitation is just a matter of what the numbers look like. Normal people will stop exercising because of cardiac output limitation. All right, this is the Wasserman 9-panel display. I want you guys to remember we said we were going to identify the ventilatory threshold. So where did this guy hit the ventilatory threshold is basically what we have to look at. So VCO2 to VO2, this is where the V slope method. So in my opinion, round about here is when there's a subtle change in the takeoff of this curve. So that would occur around at 3 liters per minute, okay? The second one is looking at the ventilatory equivalence. I told you at anaerobic threshold, you're going to increase your minute ventilation out of proportion to what your peak VO2 is not going to increase much, and your VCO2 is actually not going to be able to keep up with your minute ventilation. So this is why this ratio goes up. Both of these ratios go up at anaerobic threshold, and you see the crossover occurs almost about the same point. So this is where it's occurring here. So that corroborates to 280 watts. And I'll show you in just a moment when we look at the raw data, how you can look at that. Again here, this is looking at the minute ventilation that will go up out of proportion to VCO2. And if I drew this curve here, this angle is different. So this is kind of where I would mark it. Again, occurring at around between 2 and 4. Somewhere around 3.1, 3.2 liters per minute is it. So the most important thing is, was there an anaerobic threshold? Did the patient hit an anaerobic threshold? The answer is yes. And we're trying to predict where he hit it. This is a difficult task. This is what Arvind is talking about, RER. So RER of 1 or more. So once RER, as you know, is basically just the ratio of VCO2 to VO2. And once you hit anaerobic threshold, your VCO2 carbon dioxide production goes up, because once you start producing lactic acid, it gets buffered by bicarb, and the byproduct is CO2 and water. So your VCO2 production will go up much more than your VO2, because you're already reached anaerobic threshold and your peak VO2 won't go up. So RER of 1 is occurring around this point, which is again around 280 watts. You see this arrow, if you can bring it down, it's around 280 watts. Here, I'm also estimating around 280 watts. So let's see then. So 280 watts, if you look here, this is the workload. We go to 280 watts, somewhere around that, 271, 280 watts, and you see that the VO2 was 3.2 liters per minute. Make sense? That is exactly what we estimated roughly from the V-slope method, that it will be around 3 liters per minute. So that means it's quite consistent. We looked at several things. So now we can just say that this was where the anaerobic threshold occurred. The total was 4.3, the total liters per minute of peak VO2. So you'll take the ratio. So at ventilatory threshold, you hit anaerobic threshold around 70%, which is well within normal range. As a matter of fact, only athletes will hit that. Most people will hit their anaerobic threshold around 50 to 60%. So that's normal. Okay, guys? Any questions regarding that? How to review the things? If not, I want to move to the pathological cases, and then it's a transition. There are going to be several. Hopefully, we can get through 5 or 6 of them. So this is a 60-year-old female with a mild dystonia exertion, like class 2 symptoms, but noticeably different. I think she was an RN, and she was having shortness of breath, and she got this MVO2 performed. Okay. Weight is 86.4 kilograms. FEV1 is 2.15, which is 79% predicted. FEV1 to FVC ratio is 73. MVV, now again, you can use 2.15 times 40. Probably doesn't hit quite this. They actually measure MVV, so they measured 106 liters per minute. All right, so this is her data from the cardiopulmonary exercise test. Now you're looking, so VO2 max is 1166. Hers predicted was 1373. And so that is about 85% predicted. Not entirely normal, maybe mildly abnormal. What does it translate to in kilograms per minute? 14.1. So that is 66% predicted. That is what we typically go by as index to weight. And you see here, peak VO2 is low. It is about moderately impaired, less than 15, and 66% predicted. So it is abnormal. So the first thing to acknowledge is that this is abnormal. Heart rate response. So her predicted maximum was 159. She hit 128. So there is some chronotropic insufficiency, 81% predicted, but not that bad. O2 pulse, her predicted was 8.6. Anything less than 10 is considered abnormal, but as you can see, her maximum was right about what was predicted for her. So I would say that O2 pulse in her, in the most part, we cannot say that this was necessarily a problem. Blood pressure increased with exercise. Her maximum minute ventilation at peak exercise is 56 liters. Her predicted maximum based on the MVV that I showed you was 106 liters. So that is about 53%. So she has a 50% ventilatory reserve here. So again, already you guys can begin to think that this may not be a pulmonary limitation, but you are seeing a low peak VO2 so far, 66% predicted based on that. You see some heart rate sluggishness. The O2 pulse looks pretty okay. Blood pressure is compromised. Respiratory rate went up, tidal volume went up. I think those are generally what you're looking for, that they go up with exercise. Oxygen saturation, there was no desaturation. And the PET CO2, as you know. Sorry?
Hey, Dr. Hussain, real quick. So can you go through your logic once again, how you know definitively this isn't a respiratory issue?
Oh, because patient's maximum ventilation and her maximum voluntary ventilation is 106. This is what she could get to if she needed to. She never reaches it. Like, she's not even 50% of that. So her lungs are like feeling really good right now. All right. Okay, when she's stopping to exercise for whatever reason she's stopping, the lungs are feeling really good. There's a lot of reserve there.
I see. I see.
Okay.
Thank you.
Imad, to maybe clarify that, when we're looking at VO2 max, we're saying predicted is, something, and then you've not reached it.
Yes.
How can we distinguish here that ventilation, she's at 56% of what she could, but the limitation is, like, how are you able to say here that the limitation is she's not reached her predicted max, but she has predicted max? Because
the way you'll be able to distinguish is she hits anaerobic threshold and RER was good, then she hit anaerobic threshold, so she's already in anaerobic metabolism, so it was an adequate effort. The only reason you can't, your point is that if your ventilation is not hitting the breathing reserve to the maximum of it, is the patient just not reached that limit and they just stopped exercising soon, right? But that would not be the case if they've hit anaerobic threshold and their RER is greater than 1.1. That's how we will distinguish that. So that's coming up in the next page. So
I guess to look at it in another way, if this was a ventilation problem, you would probably max out here to the max, closer to your predicted max by the time you reach your anaerobic threshold, because that is the limitation, correct?
If you have a ventilatory limitation, no, your peak VO2 is still very compromised. Peak VO2 is what potentially, predicted max is what you could potentially get if you had normal cardiopulmonary responses. But no, it's actually, see, the problem is when you're limited by your ventilation, you'll stop well before. If it's purely ventilation, like COPD, you will actually stop even before you hit anaerobic threshold. You're just stopping, your heart is getting enough oxygen delivery, it's just that you just can't breathe. And you stop because of shortness of breath, and you're just out of breath. So right now, we see a good ventilatory reserve. We see the O2 sat not dropping, and the PET CO2 is decreasing with exercise. So for example, PET CO2 is also a measure of ventilatory failure. So if you have ventilatory failure, you're not going to be able to ward off carbon dioxide, right, when you're hyperventilating. In fact, it will either stay the same or start going up. So those are the three things you can look for right away out of this table to do pulmonary versus cardiac limitation. Now, I also told you a symptom limitation. Most people that have pulmonary limitation stop for shortness of breath, But majority of patients in most papers that are published, and I agree with this, even in my experience, the cardiac output impairment, they stop for leg fatigue. And so that's the reason why they stopped. Okay. All right, so this is the raw data. This is what you are going to be looking at, what you're going to get in the form of raw data. And here you can see the RDR at peak exercise is well, before recovery, 1.38. Okay, so it's a very good effort. And let's look at the CO2 curves now. First thing you want to see is, did the patient even hit anaerobic threshold? So here you can start seeing that the ventilatory equivalents, there is a crossover, and then there is this increase here and increase here. So you most likely the patient hit anaerobic threshold, not most likely, but certainly the patient hit anaerobic threshold, okay? And so RER, this is the RER one, RER exceeded 1, so you know the patient hit anaerobic threshold, and then continue to increase during the remainder of exercise. And then your PET O2 also increases at ventilatory threshold, and your PET CO2 starts coming down when you hit ventilatory threshold. So all of these, in the interest of time, because I've already gone over it, how you can look at it from the raw data, basically the ventilatory threshold was met, and so patient did reach anaerobic threshold. Patient had a low peak VO2, had, let's go back. So low peak VO2, 14.1, normal pulmonary response, has some heart rate reservation, but predominantly is showing a mild to moderate cardiac output limitation to exercise, right? So, and the reason you know that patient hit anaerobic threshold, it was limited by heart, peak VO2 was reduced. Yes, you did not have a low O2 pulse, but it doesn't have to be, right? It is just putting the things together. And in this particular case, the VE-VCO2 was also, I think the slope, I don't have it written, but it was 32. So it was also not abnormal. Okay.
Imad, just a quick question.
Yes.
You don't have to give a long answer, but the delta blood pressure,
yes,
has that been incorporated into the multivariate studies that have validated the VO2 max as a good predictor? Like if somebody on exercise, the blood pressure goes from 100 in your case to 120 or 110 versus going up to 170.
Yep. Yeah, so in a different context, yes, Arvind, it's called the cardiac power index. And so they're using peak VO2 times times the systolic blood pressure and times blanking out on the equation. So
but the CPO, they're using that peak to calculate the peak CPO.
Correct.
Okay.
And if that systolic blood pressure, and then based on cutoffs that they have, you can prognosticate above and beyond what peak VO2 is giving you. Absolutely. You're 100% correct about that. As a general rule, obviously a hypotensive response is a very, very bad sign. A blunted cardiac blood pressure response is also not great. And then a hypertensive response, if your systolic goes over 220, that is also not a good thing. But beyond that, I agree with you that it's called the cardiac power index, and they use peak VO2 as a surrogate for the cardiac output, and they put systolic blood pressure in as more prognostic than the peak VO2. It's just not translated into our clinical practice, but there's data out there regarding that. Okay, case number 3 is a 61-year-old male smoker and has shortness of breath with exertion. Okay, we'll start with FEV1. Right off the bat, you can see it's 0.43, which is 12% predicted. FE1 to FVC ratio is extremely low at 0.23. MVV is only 16 liters per minute. All right, so already you kind of know that based on spirometry alone that this guy is going to have significant limitation. But let's go into what is next. All right, so his VO2 max was 8.1 mLs per kilogram per minute. His predicted was 31.3. So that's only 26% predicted, very low peak VO2. If this was a heart failure patient, we would list him for heart transplant. Heart rate response at rest, 82 to maximum 111. Percent predicted was 70. So 158 was his predicted max. So again, there is a chronotropic element here, or maybe not. Maybe he just stopped exercising first for a different reason, and his heart rate never got a chance to get to its maximum, okay? The third thing is the O2 pulse, and in his case, it was 5.8, but his predicted is 13. So just keep an eye open for this. Yes, these are abnormal. There's chronotropic incompetence. The O2 pulse is low, but that's only relevant if you're limited by your heart, right? If you get limited by some other situation, then that is what Arvind was trying to say. Then, you know, hypothetically, if the patient was not limited by, say, his lungs, he would have been able to achieve a O2 pulse of maybe 10, 12, and heart rate that reached 158, okay? Blood pressure, hypertensive at start, went up, but went up with exercise. Ventilation, so his maximum was predicted at, his maximum ventilation was 16. His predicted max was also 16. So he reached 100% of his maximum voluntary ventilation. Respiratory rate went from 17 to 34. Look at the tidal volume. At rest, 0.87, 870 ml, went down with exercise. What is that telling you? It's telling you air trapping. Patient is trapping air. Oxygen saturation went from 98% to 93%. Now, even though technically speaking, he did not go below 90% or 88%, depending upon who you talk to, but it was a 5% decrement. And on stopping exercise, if this takes a while to improve, this will be considered as oxygen desaturation. In his case, it took 5 minutes for the patient's oxygen saturation to come back to its baseline. Okay, and the last was PET-CO2. I told you it's a marker of ventilatory failure. When you're hyperventilating, right, in this case to 34, your PET-CO2 needs to go down, not up. And his PET-CO2 went up to 57. So just summarizing this table, very low peak VO2, definitely a heart rate response that is not adequate and an O2 pulse that is not adequate, but it has to be taken in context. And then he completely reached his ventilatory reserve. His tidal volume went down with exercise. He had O2 desaturation and PET-CO2 went up already. And his reason for stopping the test was shortness of breath. So already, most people will say this is a ventilatory limitation. But let me make it even more clear to you. By the way, I have to tell you this. Look at this. This is one condition in which you don't meet your RER. Look at his RER. At peak exercise, this guy stopped because he was huffing and puffing. Look at his RER, 0.72. Would you call this an inadequate effort? The answer is no. The patient was having a lot of shortness of breath. He's already reached his ventilatory reserve. He cannot go anymore. It's not that the guy's not getting enough effort. It's just that his lungs limited him before he could even hit anaerobic threshold. So look here. Tell me, where's the anaerobic threshold? There's no crossover. Where's the anaerobic threshold? This is real data. Can you see any anaerobic threshold here anywhere? And if you look at the RER curve, it doesn't even hit one. So there is no anaerobic threshold in this patient. He never reached ventilatory threshold. So he never reached to a point where the heart could say that I can't provide more oxygen delivery. We're going to now shift to anaerobic metabolism. So this is hands down limitation, pulmonary ventilatory limitation to exercise. This patient ended up having severe COPD. Next case, 59-year-old male. By the way, anyone have any question on that? That was like a really wide open pulmonary limitation, but did anyone?
Yeah, Imad, I have a question. I mean, that one's obviously straightforward, but someone, that has COPD and bad heart failure, we don't get ABGs routinely with our metabolic stress test. So do you ever order them specifically? And then in what context do you do that?
So Barry, the answer is that, as you know, I have not been in the CPET lab here, but University of Washington, Seattle, it's pre-planned. If you feel like you're uncertain of what the patient's gonna be, like if someone comes in for heart failure prognostication, they're not gonna get an ABG because you're just trying to see they have known heart failure, their limitation, you're just trying to see. But if someone has unexplained dyspnea on exertion and they have some risk factors, you view the tank, you put in an arterial line, and you do ABGs as you go along. It's the ultimate way of trying to figure out, tease out these things. So at UW, that's how it happened. You would put an arterial line and you would sample it every 2 to 3 minutes.
So Imad, have you ever ordered that here? And is there a way we can establish that there for some of the more complex patients?
Yeah, so Barry, I mean, I'm trying to get into the CPAT lab more and more, and if I get an opportunity, you know, I'll eventually present to you guys that I want to even set up an invasive CPAT lab, so we don't have to go with this non-invasive cardiac output. And yes, at that time we should do ABGs. And right now, if we order an ABG, it's being done in our outpatient center here. They don't have the capability like on Smith 19 to place an arterial line and get blood gases. They can do a blood gas if you ask them, the nurse can, but that's it's like an exercising patient. You're trying to poke them to do a blood gas is just not efficient, and it actually can be, you know, cause pain, and you can have an erratic breathing pattern as a result of that, and it can mess up the interpretation of the CPAT. So right now we can't do it, man. I know it's kind of we're kind of limited in our capacity here. Okay. 59-year-old male with known sarcoidosis, okay, for a long time, with dyspnea on exertion for several months. All right, so let's go through this. FEV1 1.8, which is 56% predicted. It is not normal, but it's not horrible. FEV1 to FEC ratio is 0.69, just below 0.7. Maximum voluntary ventilation is 74 liters per minute. So let's see how he performed. So his VO2 was predicted was 28.9. He reached 11.6, which is abnormal, which is 40% predicted. So his peak VO2 is low. Heart rate went from 75 to 135, predicted max was 161. So reaching about 84 to 85% predicted max. So not bad. O2 pulse here, his predicted was 11.2. His O2 pulse was 11.3. Blood pressure increased with exercise. Ventilation, so rest 14, maximum minute ventilation 67.8. His predicted max was 74. So even though he didn't reach 100% of it, he reached 92% of the max, which is again considered an impaired breathing reserve. You should have at least 15% breathing reserve at peak exercise to say there is no ventilatory limitation, okay? Respiratory rate went up appropriately, tidal volume went up appropriately, O2 SAT dropped by 6%, and this was sustained, so this will be considered exertional oxygen desaturation. PET CO2 actually did not increase, so it went down slightly. And this is the VDT to VT. The only way, I've showed you the equation now many times, is to do an ABG. And from rest to exercise, as you know, normally this ratio should decrease with exercise, because as you improve cardiac output, you have better perfusion of those alveolar capillaries that were not recruited, and your VD upon VT goes down. But in this case, it went up, suggesting that there is a worsening dead space ventilation, suggestive of several things, and we'll have to figure out in this case what it is. So let's go to the next. So this patient stopped for leg fatigue. What clue does that give you? So the patient is not stopping for shortness of breath. He's stopping for leg fatigue. So it could be a circulatory impairment, but that is yet to be, because there's some ventilatory impairments here. The peak VO2 is reduced. The O2 pulse is normal, and he's stopping for leg fatigue. That's all we know so far.
Dr. Hussain?
Sure.
For the ventilation.
Huh?
For the ventilation, you said that it's not really good for this guy, like being 92%, and you mentioned something about the 15%. Can you repeat that idea?
No. So his breathing reserve is reduced, right? He reached 92% of his maximum voluntary ventilation. At best, you should reach 85%. You should have at least a 15% breathing reserve. Does that make sense? At peak exercise, to say that it's not a pulmonary limitation to exercise, okay? All right, so let's move here. Let's start with here. RER, at peak exercise, it did hit above 1.1, so it was an adequate effort, but also telling you that you probably hit anaerobic threshold. So let's look here. So already you can see that yes, there's crossing over, and you can see that the VEVO2 is going up here, and the VEVCO2 is going up here. So somewhere around here, and again here from the V-slope method, you can see somewhere around here at the RER when it hits one, somewhere around here, and then the PETs, O2, PPAT, O2 going up here, and PET CO2 going down here. So around here, you did hit anaerobic threshold. Based on these displays, I can clearly say that this patient hit anaerobic threshold, and you know that the RDR was greater than 1.1. So this patient did hit anaerobic threshold. That means that to some degree, this patient, not to some degree, but there's a very good chance that this patient stopped exercising. Not a very good chance, for sure, this patient stopped exercising because of cardiac output impairment. Now, we have to put it together, right? So this is where, I'm just showing you with the arrows where the ventilatory threshold came. Okay, so we look at the ABG here. ABG. This is the ABG at unloaded exercise at 2 minutes, 3 minutes, 5 minutes, and maximum exercise. You can see here, I told you these two are the parameters that tell you about gas exchange. So here you can see that the VD upon VT increased with exercise. It should decrease with exercise. So this is telling you more dead space ventilation or gas exchange is very abnormal. And this is, the AA is kind of telling you the same thing. I told you less than 35 is normal, with peak exercise is hitting 53 millimeter or mercury gradient between the alveolar arterial gradient. So this patient has a severe gas exchange abnormality at the alveolar capillary membrane. So putting that together with a low peak VO2 that hit anaerobic threshold and a VE to VCO2 that hit 36, telling you that there's ventilatory insufficiency, you can conclude that this is a combination of cardiac and pulmonary impairment. And what would do that is it would be pulmonary vascular disease. So this patient ended up had a right heart cath, had moderate pulmonary hypertension, and this chest CT did not show interstitial lung disease. So I just want to summarize here that the overlapping pattern in particular is a situation where the ABG will be very helpful. And in this case it was telling you that there's a gas exchange abnormality. So either it's interstitial lung disease, emphysema, or peripheral vascular disease. Those are your three differentials for gas exchange abnormalities. And that can be, as you know, simply by a simple diagnostic tool, you can differentiate them. So this patient had pulmonary vascular disease. And so a pulmonary vascular disease is a situation where you have impairment in all of them, both the cardiac and pulmonary parameters. Now, typically, although in this patient it didn't occur, your O2 pulse will also be low, because O2 pulse is your stroke volume. And if your RV is not performing well, say this patient had severe PH, then his VE, VCO2 would have been very high, like 40s, 50s, and his O2 pulse would have been very low. That would have told you that his RV is just not performing well with exercise due to severe pulmonary hypertension. Now, this guy had moderate pulmonary hypertension, and that is why he did not have all of the derangements that you would see in an overlapping condition like pulmonary vascular disease. Okay, I don't know how much you guys can hang out longer, but I have some really good cases that are.
Dr. Hussain, can I ask a quick question? If you go back to the chart, the 9, I forgot the name of that. Yeah. So here, when we get I'm trying to look at the flow chart that you gave for the differential diagnosis, working our way down. So if we have a peak VO2, we know it's low. Yes. And then we're looking for anaerobic threshold. And then the cutoffs there, they give us 40% of predicted peak VO2.
Correct.
So where is that 40% coming from?
No, so yeah, so I mean, here, listen, so I didn't write down where this patient hit anaerobic threshold, but let's just do it right now. So say he hit it at 1.25 mLs per minute. Let's go to his, okay, so at VO2 of 1.25 right here, 50 watts is where he hit anaerobic threshold. So 1.25 over 1.52, which was his maximum. Liters per minute. So that ratio is going to be more than 40%. That is not, that parameter is not met in him.
Yeah,
you don't
so he's
always have a low 40%. Okay, 57-year-old female who has chronic heart failure due to LV systolic dysfunction with an estimated EF of 35%. She was being treated with optimal medical therapy, including diuretics, ACE inhibitor, beta blocker, and statin. Exercise testing was performed to grade the severity of her impairment. On the day of testing, there were no findings of volume overload, and ECG showed sinus rhythm with prolonged QRS due to interventricular conduction delay. All right, so she's 57-year-old female. Her weight is 60 kilograms. This is her FEV1. It's 2.55 liters. Her predicted is 2.64. MVV predicted was 97. Her measured was 123. So this is the one we're going to go by. Her MVV is 123. All right, peak VO2. These is in liter per minute, but this is kilo index to weight. What ended up being 14.5, which is limited. Her maximum heart rate reached 136. Her predicted was 163. So roughly maybe 80%, but not bad in terms of chronotropic incompetence. O2 pulse. Her predicted was 8.5. She hit 6.7, so which is much low, suggesting already that there's an inability to augment stroke volume. This is what I told you about the delta, the VO2 work rate relationship. Remember I told you it should be 10 ml per minute per beat per watt? This was 7, okay? This is also telling you about cardiac output limitation. Anaerobic threshold, she hit at 50%, 52%, but she did hit anaerobic threshold according to the chart here. Blood pressure increased, but not much with exercise. Maximum ventilation was 45. As you know, the MVV was what? Was 123. So she's not even close to her breathing reserve. So she has like 78% breathing reserve remaining, 78 liters per minute breathing reserve remaining. So well short of reaching her ventilatory reserve. Her VE/VCO2 at anaerobic threshold was 39.4, which is very abnormal, greater than 34. Now, I wanted to point out a few things. This is the Wasserman plot again. So a couple of things that you guys see right away. Do you guys see this oscillation? This is, now look at the tidal volume. Where's the tidal volume here? It's a tidal volume, but this is kind of very dense. But here you can clearly see that almost about halfway or a little beyond halfway of exercise, there is oscillatory breathing present. This is a very poor prognostic sign if you see it in heart failure. The other thing you see here is, look, the total, this is your VO2 over heart rate, your O2 pulse. Look at it, it plateaus early until this is the end of exercise. So it plateaus early and the number is way low. So this is clearly telling you that there's a stroke volume limitation to exercise, all right? Those are two important things. Then patient did hit anaerobic threshold, as you can see with the ventilatory equivalent plot, it crossovers. And then you can see by the RER that increased then greater than 1 at around 9 minutes, and then it continued to increase. So the patient hit anaerobic threshold at around where was it? 52%, had a low O2 pulse, had a low VO2 to work rate relationship, 7. I told you 10 is normal. And breathing reserve was very good. VE/VCO2 was very bad, 39.4. It's a very poor prognostic sign, and also had oscillatory breathing. So this patient has even though her peak VO2 is 14.1, this patient should be listed for heart transplant, right? Because she has severe cardiac output limitations, which I told you, with the O2 pulse, with the VE/VCO2, with the oscillatory breathing. And so this is a classic example of a cardiac output limitation to exercise. And this is a 60-year-old woman who was evaluated for chronic cough and moderate shortness of breath. She has hypertension, and she's treated with a beta blocker and a diuretic for that. ACE inhibitor was not prescribed because she was having chronic cough. Never smoked. ECG was normal at rest. Okay, so 60-year-old female, right? Weight is 59 kilograms. All right, go straight to the FEV1, 1.76. It is abnormal, but not that bad, but it is abnormal. FEV1 to FVC ratio, 64%, which is abnormal. So there's, this spirometry here is abnormal. The DLCO is also low at 11.1, which is also abnormal. MVV is 70 measured. It is less than what was predicted, but 70 is the number we're going to use to compare. So here are her numbers. Her peak VO2 is one, oh, you guys, I did a mistake. I didn't calculate the index calculated for the kilograms. But just bear with me for a second. So the peak VO2 was reduced 1.07. And her predicted was 1.31. And this is less 80% predicted. So basically it was abnormal. It is not severely abnormal, but it was abnormal. Here you can see her heart rate went up to only 113, her maximum heart rate being 160. Already you're starting to think that there is an element of chronotropic incompetence here. The O2 pulse, her predicted was 8.2 ml per beat. Look at her number. It's actually over 9.5 mLs per beat. So it is actually higher than normal. There's something to note. VO2 to work rate relationship, it should be 10. I told you this is a standard number to keep in mind. It's the standard number. And it was low. But we don't know if it was low because it is a cardiac output impairment, but we don't know if it's heart rate related or stroke rate related. Because if you go by the O2 pulse, which is the stroke volume marker, it's actually high. Anaerobic threshold was hit at 50%. Blood pressure started high, increased to 200 over 100. Maximum voluntary ventilation was 54. Hers was 70, so she has a good breathing reserve. And it's about 16 liters per minute. VE/VCO2 was 31.5, so it's probably normal. VE/VCO2 was normal. Oxygen saturation was normal. All right, this is the thing that I wanted to point out. Look at the O2 pulse curve here. It is normal. Her O2 pulse is increasing normally with exercise, but the brown line, which is representing the heart rate over time, is very blunted. So what happened is they stopped this lady's beta blocker. That's all they did, okay? So you can see the peak VO2 went up immediately. The heart rate went from 113, now it's going up to 156. The O2 pulse now normalized, so the heart doesn't have to overcompensate because now it can do it by heart rate. So it went down to 7.8. The peak VO2 work rate relationship improved. Anaerobic threshold now moved from 50% to 80%. Blood pressure, well, you know, she was hypertensive, so she was being treated for that. And everything else remained constant. And look at the curve now. So your O2 pulse is still normal, but look at your heart rate response. It's gone up beautifully. Your VO2 went almost normalized. And so this is a classic example of chronotropic incompetence. And so the key distinguishing factor is going to be your O2 pulse here, because this is not a stroke volume limitation. So your O2 pulse will be supranormal. Okay, so that is I have a deconditioning case, but we are out of time. I'm sorry. But I hope that this helps you guys interpret cardiopulmonary exercise testing.